Welcome to this evening's webinar, everyone. Another edition of the IAOP webinar series. And this evening, we're looking at the really important topic of Valproate and the PREVENT program. Um, so just by way of domestics, I've said quite a bit of this already. So this webinar is being recorded, just so you're aware, and will be posted on the IAOP website in the coming days. As I mentioned, please keep yourselves muted for the purposes of the recording, and you can have your cameras on or off as you so wish. If you are having any difficulties, probably best to leave and to come back in. But we do have IT support as well in the background. You can keep an eye on any major issues that are cropping up for anybody. We very much welcome questions or comments on the presentation. We will allow time for questions at the end. So if you can hold fire till then, that would be fantastic. If you are on a PC and you just scroll over the screen and the chat function should appear at the bottom of the screen. And we'll circulate a post-webinar survey as well and get some anonymized feedback. So I'm delighted this evening to be joined by an excellent speaker on this subject. So Dr. Elisabeth Doran, and she is clinical lead for the PREVENT program and director of the epilepsy service in St. James's Hospital. So Elisabeth will take us through her presentation, and as I said, then we will allow questions at the end. So Elisabeth, whenever you're ready, we can get going.
So I'm going to share my screen.
Lovely, thank you, Elisabeth.
Hold on. Okay, so hello everyone. Thank you very much for having me today. I'm going to talk about Valproate and the PREVENT program. So this is just an overview of what I'm going to talk through. And so Valproate has been around for a long time. It was first derived from the valerian root in the 19th century. And it was first licensed as a medication in Ireland in 1975. And here on the side, you can see a graph of all the different anti-seizure medications that are available. And you can see it there in the middle as a second generation drug. So when it came on the market, there were fewer choices for patients with epilepsy. Currently used to treat epileptic seizures and also affective disorder. And we do know that for generalized seizures, so some patients with generalized epilepsy, it works better and it's better tolerated than some other medications. So it is a good anti-seizure medication. And it remains one of the most commonly prescribed anti-epileptic medications in the world. So it is a short chain branched fatty acid. Most formulations come with salts, so that's why it's called sodium valproate. I'm sure you all know this as pharmacists better than I do. And but the mechanism of action is not fully understood, but it acts as a sodium channel blocker and also an NMDA receptor channel blocker. It modulates the GABA transmission via its ability to inhibit GABA transaminase activity, and together, the sense is that this promotes a net calming effect on brain activity, and that this is the way Valproate works to reduce seizure frequency in patients with epilepsy. So it's been known for quite a long time that it is teratogenic, so it increased risk in fetal malformations was first reported in the 1980s, and then in 2013, data first emerged to show that Valproate exposure in utero also causes developmental disorders. Because of these findings, the EMA recommended strength restrictions on the use of Valproate in girls and women in 2014. And then further on in 2018, it strengthened these recommendations and advised that Valproate should only be used under a pregnancy prevention program. So we do know that if babies are exposed to Valproate during pregnancy, that about 1 in 10 babies can develop a malformation of their body at birth or during the pregnancy. And that can be different types of malformations, such as cleft palate or spina bifida or limb abnormalities, or also organ abnormalities. And then we know that 3 to 4 in every 10 children, so that's 30 to 40% of children who are exposed to Valproate in utero develop serious developmental disorders. So the risk of autism is about 5 times increased, and the risk of ADHD is also increased. So it's a very serious level of heterogeneity. Because of the EMA restrictions, the HSE Chief Clinical Officer commissioned the HSE Valproate Response Project in 2018, and so that was prior to the PREVENT program. So it was to ensure that when people who've been exposed to valproate in utero and impacted by this are provided with the information and support. Part of this project was also to develop an assessment and intervention pathway for children and adults who may have fetal valproate syndrome. That was mainly done with the CHI, and these pathways are in place now. And it was recommended to implement the Valproate pregnancy prevention program. And it was also advised that a program for women's health and epilepsy has to be established. So the aims of the PREVENT program are to support the implementation of the guidance provided by the HPRA, to provide clinical guidance, and to ensure that the information on the risk of valproate is available to women of childbearing age and to girls and pregnant women. The aim is also to support the communication and collaboration between clinicians who are managing the pregnancy prevention program and those who are prescribing valproate. And then it's also aiming to support communication and collaboration between prescribers and dispensing pharmacists. And is also one of the aims to develop a pregnancy drug registry for valproate. And I will talk about that later. And the aim was also to establish a pregnancy register for women with epilepsy. So the HPRA guidance in the PREVENT program is that treatment with valproate has to be initiated and supervised by a specialist who's experienced in the management of epilepsy or bipolar disorder, and that valproate should not be used in girls or women of childbearing potential unless there's no alternative. So if no other treatment is effective or other treatments can't be tolerated. And the PREVENT program has to be followed. So patients have to be reviewed annually by their specialist, and the annual risk assessment form has to be completed. And women of childbearing potential have to be on effective contraception. So we'll go into that into more detail later on. But there's very good information material available from the HPRA for patients who take valproate, and that's the front page there on the picture beside the text. So when we prescribe valproate, we have to make sure that we assess patients for pregnancy potential, and we have to explain the risk of congenital malformations and neurodevelopmental disorders to the patients. We have to perform a pregnancy test prior to the initiation and also during the treatment if required. We have to counsel our patients for the need for effective contraception throughout the treatment, and that means ideally it's user-independent contraception such as the coil or the implanon, and if that's not possible, it should be a combination of 2 different types of contraception, including one as a barrier method. And then it's really important to explain to women who have to take valproate that if they do plan pregnant, that if they want to become pregnant, it needs to be planned well, and that they need to talk to their specialist early on about this so that a pregnancy can be planned and we can aim to reduce valproate or take the patient off valproate. And also the patient needs to be counseled that if they do become pregnant, that they need to contact their specialist immediately or their GP. And patients should be provided with this patient guide that's in the picture here every time the annual risk assessment form is completed. And this should be done at initiation and every annual specialist review. So this is what the annual risk assessment form looks like. It's quite a complicated form with a lot of text. The first part is just to identify the patient, and it gives all this information again that has to be explained to the patient. And then the first part is called Part A, and that's a part that is actually for the specialist to decide, does prevent apply to this patient. So some patients may not be maybe of childbearing age, but not of childbearing potential, and there may be many different reasons. But there's some often what can be a typical reason is if, say, someone had a hysterectomy, or if someone is in 24-hour care, or they've already gone through menopause. So there are many good reasons why there's no chance of pregnancy for a woman of childbearing age. But then, so this was added to the form so that those women don't have to go through this risk assessment every year, even though they don't have a potential to become pregnant. So it's really important to have this part. But that's, so first you decide if prevent actually applies to the patient. So if it does, then the next part has a Part B and Part C. And Part B is for the specialist to complete, and they basically go through all the risks and explain every all the details to the patient, and then they have to sign this, and the patient also has to sign that they have understood the risks and that it was discussed with them. So it's quite a detailed form. And so that's the prescribing part of Valproate, and then we're going to go on to the dispensing part. Now I'm a doctor myself, so I don't dispense Valproate. So this is you might have more knowledge about this than me, but this is what I can tell you based on the HPRA guidance. So when Valproate is dispensed, the patient should always get a patient card that should be attached to the packaging of Valproate, and that should happen each time Valproate is dispensed. And there's an image of the patient card here beside the text. And there should always be a visual warning that informs healthcare professionals and patients about the risks to an unborn child. That should also be on the blister pack and on the outer packaging of Valproate. And here is the sticker of what this should look like. And then every time Valproate is dispensed to to girls or to women of childbearing potential, the pharmacist should provide the Valproate patient card. And they should always remind the patient of the risk of birth defects and neurodevelopmental disorders, and to avoid pregnancy, and reinforce the use for effective contraception. And Valproate should always be dispensed in the original packaging with the outer carton and the warning text and symbol still attached to it. And if the packaging cannot be provided, then a copy should be provided with the leaflet, and as well as the patient card, and a warning sticker should be attached to the bag. And the pharmacist should ask the patient if they've received the Valproate patient information guide, and if they haven't received that, then to provide a copy, and they can be downloaded from the HPRA website. And there's also a very good information leaflet for clinicians that includes all the information for doctors, nurses, pharmacists. So it's very useful. The HPRA website actually gives a lot of information on that, and it also has all the so like this dispensary poster and the patient card. So if it's not available, if you don't have a hard copy in the pharmacy, it can actually be downloaded quite easily from the HPRA website. And I have that at the end, the link to that. And then the patient should always be reminded of the annual specialist review. And then I was asked to highlight the differences between the guidance in the UK and Ireland. Now, I haven't worked in the UK, but there is a difference in the guidance. It's a lot stricter in the UK than in Ireland, because the MHRA changed the legislation in 2023, and they have advised that Valproate should only be dispensed in the full original packs. And so that's a bit stronger than here. And they also have changed how you can initiate Valproate. So in anyone, male or female, under the age of 55, it can only be prescribed if two specialists decide independently that it is necessary to prescribe valproate to the patient, and that there's no other effective or tolerated treatment. So that's a lot stricter than in Ireland. In Ireland just has to be one specialist, and the guidance in the UK also includes male patients, which is not the same in Ireland. And if a woman of childbearing potential or a girl is taking Valproate, they now have to have a second specialist signature each time an annual review is completed. So that, I mean, that's that's a lot, very strict. So, and then I just wanted to, so because you want, you wonder how do all these guidances and measures, how do they actually affect how we prescribe? And we have nice data in Ireland from PCRS data from the long-term illness scheme, and to show that there has been a reduction in prescribing in women of childbearing age in Ireland since the introduction of the restrictions, and also since the introduction of the PREVENT programme. So in this graph, which is, some of the data is unpublished, so I hope nobody will make a copy of this, but it shows that you can see, so it starts in 2008 and goes till 2024. And the red line is the long-term illness scheme, and the yellow line is the GMS. But because the long-term illness scheme wasn't used as much in the past, that's why kind of the prescribing goes up at the start. But if you look at the total data of both together, you can see that there was a slight drop after the first restrictions in 2014, and then a more clear drop since the PREVENT programme was introduced. So prescriptions of Valproate for women of childbearing age are reducing with these measures, which is reassuring, because there is a lot of challenges with the programme and delivering the programme. One significant challenge is that it's actually really difficult to identify individual women who are prescribed Valproate and to ensure that every woman is compliant with PREVENT, because there's no registry for Valproate prescriptions. A Valproate can be prescribed by GPs, by general neurologists, by psychiatrists, and often by private practitioners as well. So it's very difficult to even identify all the prescribers, to educate them. And because a lot of the majority of the prescriptions are paper-based, and the information from the prescription is not collected anywhere in a centralized point, it's very difficult actually to find out what is the number of women prescribed Valproate in Ireland reliably, which makes it difficult to know how well we're doing with this PREVENT programme. But the data from the LTI gives a sense that we are prescribing less Valproate, which is a reassuring trend. So hopefully, ultimately, a national electronic prescribing system will hopefully make it easier to identify all these women correctly. But that's probably still a few years away. But I think that will make it much easier to ensure all women follow the PREVENT programme if they're prescribed Valproate and they have childbearing potential. So as part of the PREVENT programme, we were also trying to develop a registry for patients who are on Valproate. And again, it has been difficult so far to do this because we haven't really found a good option of how we can do this yet. Initially, we were looking at, so for patients with epilepsy, we have a national epilepsy EPR, but it was developed in Beaumont, and it's not used in all the epilepsy services. So not all women, not even all women with epilepsy who take Valproate are on this registry, and then obviously that would not include women who take Valproate for bipolar. So even though we thought this might be an option to use this, it's probably not in the near future because it's not widely enough used. And then we're currently looking at an option to interrogate the dispensing IT systems in pharmacies rather than, because it's very difficult to audit the prescribing because it's so there's so many different prescribers. But everyone who takes Valproate in Ireland has to go to a pharmacy. So that's probably the bottleneck where we could potentially identify all women of childbearing age who are taking Valproate in Ireland. So we're looking at whether this is an option to audit this data to actually find all the women. That's work in progress. So, and then I think in the long term, electronic prescribing will probably be the most sustainable solution for capturing all women or all patients who are prescribed Valproate. And it would also be a solution for other teratogenic medications. And if electronic prescribing is kind of widely used in Ireland, ideally it would be developed with a safety program so that, you know, if someone is prescribed Valproate, that you can't prescribe it unless you tick a box to say the annual risk assessment form was completed, and that is then uploaded. That would be my hope for the future, that will hopefully not be too many years away. And in terms of the pregnancy registry, there used to be a pregnancy registry in Ireland that was joined with the UK, but it's currently no longer active because it wasn't funded and supported sufficiently, and unfortunately it's not being used currently. But certainly from my epilepsy perspective, we would really love to have a pregnancy registry for all anti-seizure medications, and ideally it should be linked with the larger national pregnancy registry, and ideally should be mandatory for all women. And but we haven't actually yet developed a proper pregnancy registry, but that's one of my priorities for 2025 and 26. So hopefully I'll have more to report about this in the future. And I am hopeful that the new HSE strategy, Digital Care for 2030, will help with developing this. And then I was also asked to talk a little bit about men and Valproate. That's a more tricky topic because there was a study in 2023 that the EMA highlighted that suggests a possible risk of increased risk of neurodevelopmental disorders in children born to fathers who were treated with Valproate in the 3 months before conception. And also in the study, they showed that around 5 children in 100 men treated with Valproate had potentially a malformation compared to 3 children in 100 men of fathers who were treated with lamotrigine or levetiracetam. Now, compared to the data in women, that's a much smaller increase, and it was quite a small study, and the study was actually hasn't really been published yet, so that it's a much smaller data set than what we have on women, and it's obviously a smaller increase, so it's not as clear. It's more guidance. And also the other problem with men is that it's not a defined period of childbearing or conceiving time, because men can obviously have children all their life and conceive children all their life. So it's a very much broader problem. And so at the moment, the recommendation is that Valproate should be initiated and supervised by a specialist, but it's not that it has to be, there's no annual risk assessment form as such, and there's no request to annually talk to men about this. What we're currently doing is that if we see patients on Valproate that are males, we talk them through these risks once and document that in their chart, and make sure that they understand the risks and alert them to the patient guide that is available. But it's a difficult conversation, I have to say. because it's so much broader. And Valproate is actually a really good medication. And some patients, if they're seizure free on Valproate and they've tried many other medications, it's when it's and they might not be planning pregnancy. It's more complicated, I have to say. So, but we do alert all the patients that we have to this problem. And so what we usually say to our patients is that there is potentially an increased risk for neurodevelopmental disorders, and that it's important to consider effective contraception if a man is on Valproate, and that includes the female partner of the male, and that the contraception should be used for at least 3 months after stopping the treatment. And it's also important to highlight that male patients should not donate sperm during the treatment and for at least 3 months after the discontinuation. And again, it's important that male patients who are prescribed Valproate are regularly reviewed by their prescribers, and that it's important to evaluate whether Valproate remains the best suitable treatment for the patient. And I think hopefully in the near future we will get some more data on this, and then it might help to clarify the guidance more. And yes, so again, it's about family planning. So if a man plans to conceive a child, we need to look at suitable treatment alternatives and discuss them with patients. And then for pharmacists, it's important to ensure again that the patient receives a patient guide and patient card when they get their Valproate dispensed, and to remind the patient that there's online information, and there's also a QR code on the patient leaflet and the carton of the package so that they can get this information. And there are the resources so the HPRA, all those, the guidance, the patient leaflet, the healthcare professional leaflet, and there's also a leaflet for male patients on Valproate. So they're all very helpful resources. And then there's also on the HSE website, we have an overview over the PREVENT program. I think that's the overview of the PREVENT program.
Thank you, Elisabeth. That was really informative. Sorry, I'm hearing a little echo, but hopefully it'll go away in a moment. So thank you so much for those slides. That was really comprehensive. You'll see we have a few comments and questions in the chat. So I might start off with some of those, and if anybody else wants to put questions in, please feel free to do so. There's an observation about it being good practice to stick a dispensary warning sticker on the shelf where the effluent is stored, and I suppose that acts as a trigger that you have an operating procedure to follow there in terms of provision of the information to the patient. So thank you for that. So a question about Valproate can be prescribed by GPs, psychiatrists, etc., but ultimately the initiation and prescribing must be in secondary care. So I suppose just a query around that I think you mentioned it, that other prescribers can initiate, and that poses a challenge, but is it should it be initiated in secondary care?
Well, I think a big problem is that a lot of patients were initiated a long time ago when there were way less specialists around, and we still occasionally get referrals for patients that have never seen a specialist and are on Valproate for years. There's also a large cohort of patients with intellectual disability that are on Valproate, and they often might be in care settings and they might not see a specialist regularly, or there's also patients coming into the country from other countries where Valproate might be a much more common medication used. So I think it still happens but if newly initiated, I think it'll become a less common problem, because I think it's rarely ever newly introduced nowadays in Ireland in a woman of childbearing age. Like I can remember one female patient of childbearing age in the last year that I started prescription for Valproate because I had no other choice. But it's and even we can see with the patients that are transitioning from the children's services, we rarely ever see girls on Valproate these days. And then also because we can prescribe now for 12 months. There's it reduces the need for GPs to prescribe valproate. So I think we will move more and more towards specialist prescribing.
Yep.
But I think there's still patients out there that kind of we're missing because they haven't actually been referred to specialists.
Mm.
And so even like if you come across someone like that in your pharmacy and you feel, they should be seen by a specialist, I would love if there was a way that, you could refer the patient to us or alert the GP to refer to specialists, because I think we're at a point where Valproate should really be initiated and prescribed by specialists.
Yeah. Yeah, that's really clear. Thank you. Yeah, it's funny how, I mean, historical things can then carry forward onto, and then these kind of things can
And
happen. So thank
at
you
the
for that.
start of the Valproate response program in 2018, the way they try to identify women on Valproate was through the long-term illness scheme and through the GMS. So I think they captured a lot of patients, but because there's so many, like because of the because psychiatrists also use Valproate, and because it was in the past maybe prescribed by GPs, there probably some patients were missed, but I think the sense was that the largest part of the cohort was probably included in that. But it's
Mm.
just not. There's no definite way to really know. Like we
Mm.
don't, if there's no mandatory, no mandatory e-prescribing where you can. Where and where you can just audit and say, show me all the patients that are Valproate in this country. Like,
Yeah.
I mean, but I think we will get there in the next few years,
Yeah.
hopefully.
Yeah. Um, Question about what's the current status of a new program being initiated by the HSE for topiramate based on the new risk mitigation plan. Materials have been published for prescribers since last year.
Yeah, so I don't think there is a plan to establish a whole separate program. Um, I know that the material is out there, and it's slightly different to Valproate because it says consultant only to fill in the annual risk assessment form. Um, Certainly I know there's different prescribing practices in every service, but in epilepsy care, but topiramate is used a lot less than Valproate. So it's a smaller cohort, I think, that we're talking about. Like it's certainly, I think for epilepsy services, it makes sense to just include them into the same safety program, you know, like into the same procedures that you use to, similar to putting the sticker onto the shelf. We get our admin to highlight to us every time a patient who's a Valproate comes to the clinic, and it's the same for topiramate. It's just kind of highlighting it to yourself that they need this once a year. But
Mm.
ideally, I think this prevent program shouldn't, like, there's going to be, probably you will find that there's other medications, all our medications, the anti-seizure medications seem to have a risk for teratogenicity. And I mean, I don't think the HC will be able to set up a program for each medication. Ideally, this program will help to develop a system that is, where you can just add more medications to a
Mm.
safety system that is not specific to one medication. And Valproate, should show the way for other
Yeah.
medications.
Yep. Thank you. There's a question here about the effects of valproate on women who start taking the medication in their final trimester. Is there effect on traumagenicity at that stage?
Well, so in terms of, embryogenesis, that's obviously complete after the first trimester. So you're probably less likely to, like the baby's probably not going to develop a cleft palate or spina bifida because they're already developed. But in terms of neurodevelopment, I would assume it can still have an effect. It is dose dependent, but I think it's not actually a scenario I come across. Like, usually the worry is that a woman doesn't know she's pregnant and she's taking it during the first trimester before she even finds out that she's pregnant. But I think it's rarely ever the case that you'd want to restart someone on Valproate in the third trimester if they weren't on it in the first two. I mean, it would only be if someone was in status. That would probably be the only reason. And if someone is in status, it's life-threatening
Mm.
emergency. So you may have to focus on like saving
Mm.
a life. But it would be your last choice. Like, you would really, really try to avoid it. So I don't think there's probably no data on the comparison as such.
Okay. Thank you, Elizabeth. Um, Let's see, make sure I haven't lost. Oh, yes. What could some of the possible reasons why there might be no other choice than to use valproate?
So I think the only reason is there's some forms of epilepsy that only respond to valproate. And like some patients have, you try every other medication that you can try before you try valproate in a woman of childbearing age. But some patients have really refractory epilepsy and seizures can be life-threatening. You can be injured in seizures, if the risk of SUDEP. So if someone has very frequent seizures that don't respond to another medication, that would probably be the main indication.
Thank you. Somebody has shared a link to a paper. I know unfortunately I haven't had been able to open it at the moment, but they indicate that it's a Danish paper refuting the paternal signal that the EMA prac acted on. The warning would likely be reviewed as further studies are published with other populations. So the paternal issues. I'm not sure if you're aware of any of that research. Perhaps you're not. The
Um,
link is provided there.
yeah, just opening it.
Mm.
But certainly the EMA hasn't updated their guidance yet. And I know that there was a lot more controversy about the information that's available so far.
Mm. Yep.
So it's I think it's really something there's probably more precaution because of we know how teratogenic it is in women to it's safer to say don't conceive a child when you're on this medication. But I think that the data isn't, there's just not as much data on it as in women.
Mm.
So
And I actually had a related question with that, that I suppose in relation to the slide you had about male and precautions when taking valproate, and um, you mentioned that the female, if they have a female partner, that they should use contraception also. Are there preferred methods? Is it similar to what you mentioned before about the coil or the implant on,
we
or
don't give any, we don't give a specific recommendation. I mean, it's a lot more difficult to say to a patient your partner needs to take
yeah,
contraception.
absolutely,
And
yeah.
you're not advising the patient yourself, but it is
Yes.
usually the partner who is using the contraception in the majority of cases.
Yeah. And
So
and I appreciate you
like you
saying that it's a
can't
difficult
really,
conversation
you
anyway.
can't,
So
yeah,
yeah.
and you can't really advise someone that's not even your patient to, oh, you
Yes.
actually should be using a coil. That's way more invasive than
Hmm.
taking an anti-baby pill. So I think it's that's what I'm saying. It's a very difficult conversation to have.
Hmm.
Often the partner is in the room, and it's also often probably the partner that has the wish to have children.
Hmm.
So but I think it's important to highlight that there is potentially a risk, and that you know, like I had a patient recently, like a lot of the patients that are, because there's a lot more males on that birth, they might already have children, and they might say, actually, I already have three children, they're all well and they're fine and they don't have any issues. And Valproate has kept me seizure free for many, many years. Why would I take the risk of having seizures again when, so it's the conversation goes very different
Yeah.
to in practice
Yeah.
in a
Yeah.
but
Absolutely. Kira here makes a good point that I'll read out. So she's completed research that she will present at the HPAI conference next week on periconceptual folic acid supplementation in women with epilepsy taking anti-epileptic medications. So all these women should be taking folic acid 5 milligrams starting 2 to 3 months before conception. So in the course of the research, they found that women taking valproate had, sorry now, let me scroll down, had the worst compliance of taking high dose folic acid, and that they are the group with the highest risk of neural tube defects. It is important that all pharmacists dispensing valproate and other anti-epileptic medications tell women about the importance of taking high dose folic acid. I'm not sure if you want to comment further on that at all.
as an epileptologist or as the prevent lead.
Whichever you
Because
feel appropriate. Yeah.
there have been
Yeah.
a couple of papers that came out recently that highlighted that there may be a increased risk to babies born to women who take high dose folic acid who are on anti-seizure medications to develop childhood cancers. And there was a further paper to that, and they're all kind of Scandinavian registry studies, retrospective reviews, that women who take high dose folic acid long term probably also have an increased cancer risk themselves. And all these studies were done on patients, women with epilepsy who were taking anti-seizure medication. So amongst epileptologists in Ireland, we're much more reluctant to suggest this high dose folic acid to all our female patients because of these recent papers. And certainly in someone who takes Valproate, we would recommend high dose folic acid because, yeah, there's a higher risk of malformations. But we're currently advising our patients to take 0.8 milligrams, which again is kind of in between because there isn't because it's very difficult for us because we often ask patients to take folic acid like years and years before they actually plan pregnancy, and like say they're 20 or where, so it's so I think we need to learn more about who we recommend the high dose folic acid to, and certainly for certain medications there isn't an increased risk as such. So we've kind of probably moving towards and we would probably say 1 milligram, but it's not available in Ireland as the dose. And I think the 5 milligrams were chosen at the time when the recommendation was made based on expert consensus, not on evidence that 5 milligrams is actually a good dose, but only because it was available as a dose. And it's a lot higher than what is recommended to women, who don't have epilepsy. Because it's like between 0.4 and 5 milligrams, it's a very big difference. And yeah.
Okay, thank you. That's useful information to have and
But
to
that's
know. So thank
probably
you for that.
probably a topic in itself. It's that
It sounds like
discussion
it. Yeah.
about the folic acid. It's quite like we've had quite a few like like journal clubs about that in amongst epileptologists because obviously we're not quite sure how to how to interpret that data and what to do with it. And for example, the German guidelines have changed on the advice of how much folic acid should be prescribed to women with epilepsy, and it's just across the so it's very tricky topic.
Okay, thank you. I suppose that individual coming back with another paper, teratology services also dubious about the paternal warning. Um, I suppose I was struck by the difference between the Irish and the English approach to this. And obviously, I suppose each jurisdiction can has autonomy over how they manage things to a certain extent, obviously. Is there any particular driver for this, or how do we compare with other European countries on this? Do you know?
So I'm German, so I know the
Yes,
German guidelines,
yes.
and that's another European country. But I think we're more in the German guidelines, Valproate is still recommended very high up as long as the woman takes the correct contraception, anti-contraceptives. So I think the UK event, the UK made very, very strong recommendations. But I think if we follow the recommendations that are there, I think it should be safe. I think you can't, it's probably difficult to absolutely prevent any pregnancies on Valproate, and it may not be possible because some women might actually have to take Valproate and they still will, if they still want to have a child. I think the important thing is that we warn our patients and that we do it regularly on an annual basis and that we follow the prevent program. But I think it would be difficult to manage in Ireland to have two specialists on a regular basis. Like it's and also because Valproate is a really good anesthesia medication, I would be worried, with the UK recommendations that are for male and female patients, that patients who actually require Valproate might not be prescribed it because it's so difficult to prescribe it. Yeah. So I think it's a balance, and I can't, I don't know, I don't work in the UK and I don't know their regulatory bodies, but I think the Irish regulations at the moment, I think they're reasonable. But the important part is that we actually, that all women actually follow the prevent program if they're of childbearing potential. And I think that's what we can really work on in Ireland to make that better, that we can actually find all the women that need to be in the prevent program.
Thank you. So, like you provided extensive information there, guidance for pharmacists that, I'm sure, many of us are aware already, and we're following those to the letter. Is there anything else you think we could integrate into our practice, or things to bear in mind in addition to the guidance that's out there that would be of assistance? Obviously, the presentation this evening has given us lots of food for thought as well.
Um, I think it's important, like, if you get the sense when somebody is dispensed Valproate that they're not attending a specialist, that, especially, like, we do think that there's a lot of people coming into the country that may not be integrated into the healthcare service in the same
Mm.
way, is to, highlight routes on how to, see a specialist or even to see a GP so that they can be referred to specialists for assessment.
Yeah, that's actually a really excellent point. Kind of keeping an eye out for those vulnerable populations that could have slipped through the cracks, maybe a little. And I suppose we are the kind of a point of care, an easy access point of care for lots of individuals. So yeah, and kind of I appreciate in the context where you're saying that pharmacists are often in that bottleneck of we are the encounter that's consistent for many people. So we are a good point for that kind of thing. So thank you, Elizabeth. Um, I'm not sure if anybody else has anything else to add into the chat at this moment. I don't see anything else coming in. Um, just in case anybody else has anything, I might just kind of let you know about what's coming up in the next few weeks for the IAOP. So a link to a survey will be provided to you. It's gone into the chat there, but we will also circulate that in an email. And so any feedback you have in relation to this or any future events you'd like to see, please do let us know. We'd love to know about that. As always, we'd encourage you to log this as a CPD cycle. Even make a note of it now and come back to it later. I'm sure there's plenty of information there that has been very helpful for us this evening. Just so you know what to expect in the coming weeks. So next week there is a special edition IOP webinar. So it's outside of the In Conversation with series, and it's to make you aware of those individuals who are running for the PSI Council elections, and for you an opportunity to hear directly from those candidates, and then to encourage you to vote or think about voting for those council elections. So that is next Wednesday at 8 p.m. And then the following week we will resume with our In Conversation with webinar series, and that will be on suicide prevention with Ailish O'Neill. With the National Office of Suicide Prevention. So, as always, do keep an eye out on our various social media that are listed there on the screen, LinkedIn, etc. But if you do have any questions, you can also email the IAP directly, and they'll always be happy to help you out. So I don't see anything else coming in. And thank you everyone who's engaged with the chat. I think that really brings out a lot of the detail and things that do concern us, or things that problems or issues we encounter. So thank you for that this evening. Elizabeth, that was really excellent, really comprehensive, and thank you so much for taking us through that so expertly.
Thank you.
Thank you very much, everyone. We'll close the webinar now. Good night.